Welcome everybody to this satellite symposium where we will address the potential of artificial intelligence to fight colorectal cancer. We have some very interesting talks lined up for you on the subject, and we just briefly introduce why we are doing this seminar. As you know, colorectal cancer has worldwide a very high incidence, and accordingly, there's also a high mortality of colorectal cancer. Unfortunately, all these lesions can actually be prevented because they originate from precursor lesions that can be treated at early stage, as we know. And there is a little bit of a problem there, because in order to prevent colorectal cancer, we need to do very well in polyp detection. And as we know, for instance, from this meta-analysis of 6 tandem colonoscopy studies, the polyp miss rate can be as high as 22%. And even for adenomas larger than 10 millimeters, this can be 2%. Unfortunately, not all endoscopists are the same, and adenoma detection rate can vary significantly amongst endoscopists, which then translates into a higher rate of interval cancers in between colonoscopies. So therefore, this is now a very important quality indicator that is generally accepted. But can we actually improve this by the help of artificial intelligence? That's one of the questions we want to address here. The challenges for polyp detections are quite clear. Obviously, it depends on bowel preparation and the quality of that, the quality of your endoscopic equipment and the resolution of your scopes. But there are certainly also operator-dependent factors, like for instance, fatigue. It's been shown that people perform better in the morning. The fact that you need to do successive repetitive procedures that can sometimes be a little bit boring and you lose attention. And you can simply be distracted by phone calls, people popping into your endoscopy suite to ask things, and maybe even holiday conversations with your nurse. So this all accounts for the up to 26% miss rate for polyps that has been reported in these back-to-back and CT colonography studies. So therefore, we're going to explore how AI can help us in improving that. And Dr. Cesare Hassan from the Nuova Regina Margherita Hospital Endoscopy Unit in Rome will tell us about the discovering of new frontiers with AI. How good is it in detecting these polyps? What is available? Does it depend on the endoscopist? And do we need more than just detection with these tools? Subsequently, Dr. Micheal Häfner, who's head of department of the internal medicine in Bregenz in Austria, will introduce the PENTAX medical discovery system and show how it was developed and the first clinical result. So once we detect a polyp, we need to start treating it. Sometimes lesions like these can be difficult to delineate, and we need to know which lesion needs surgery or endoluminal treatment. So we need to consider the right clinical pathway from detecting, delineating, and then deciding which therapy is applicable for that polyp. And for this purpose, Mr. Amyn Haji, who is a consultant colorectal and laparoscopic surgeon and director of endoscopy and surgery in King's College, will guide us into the right direction on this clinical pathway in the third talk. So without further ado, I'd like to give the word to the 3 speakers who will address these issues in the next half hour. But by the end of the talk, Professor Peter Siersema from the University of Nijmegen will join us and wrap up with the conclusions of this session and discuss also the questions. So please send your questions online during the symposium so we can take them at the end of the program. So enjoy.
So thanks, Raf, for the great introduction, and thanks, PENTAX, for supporting this satellite symposium. As anticipated by Raf, the main driver of artificial intelligence is actually represented by the pitfall of human intelligence. Raf already showed how failure to recognize lesion may be due to lack of attention or of competence, and this can lead to miss rate and interval cancer. But as also anticipated by Raf, there may be a problem also in characterization, and this is probably more related with a too much expert orientated standard, but also lack of competence in the endoscopy community, where we do a lot of screening colonoscopy. This failure in optical diagnosis means a cost duplication with the pathology and inappropriate treatment. Raf already anticipated the miss rate in the lower GI, but this is probably somewhat an underestimation, because this is a lesion that without discovery would have been missed. But when you look at upper GI, where lesions tend to be more flat, the actual miss rate may be extremely higher, if not worrisome, and this is related with random detected high-grade dysplasia or early cancer that were then rescoped in expert center and visible lesion were detected. So the miss rate for a flat advanced neoplasia may be much higher than expected. And also the failure in characterization in the DISCARD-2 trial was much more suboptimal than expected, with less than 70% accuracy by endoscopies in differentiating between adenoma and hyperplastic in diminutive polyps. So the question by Raf is, can we compensate with AI? CAD-E, as Micheal will tell you deeply, can identify and localize a lesion, but we also have a prototype now by PENTAX that was shown in the ESGE satellite webinar, and this system is actually able to predict the histology of the lesion and to provide the endoscopies with an assistance. Of course, this needs to be completed in the next future, but you can see that the mechanism is already there. In order to understand if artificial intelligence works as Raf anticipated, we don't need a randomized trial. You can try to understand if AI is as good as human ground truth. And for instance, you can match the AI detection against human expert. And for characterization, you can match against histopathology. When we meta-analyze the data, the standalone performance by the AI system was extremely good in an extremely consistent way throughout detection, lower upper GI, and also for characterization, at least in lower GI. So the main feeling is that AI is quite independent from the location and also from the task, and it is very stable in its own performance. However, when you implement AI in a clinical setting, you need to analyze the interaction between the computer and the endoscopies, because maybe an endoscopist could reject a true positive that he is unable to detect, or vice versa. The endoscopist can identify a false negative of the computer, and the same with false positive result. So what we need at the end is a randomized trial, and we have some preliminary randomized trial for detection in the field of colonoscopy, showing overall a 47% increase in detection when using AI. And I feel this is in line with the estimate of miss rate shown by Raf at the beginning. And this was along all classes of polyp, although as expected, and Micheal has very nice example, this is very much more in the field of diminutive adenomas. But maybe we can also have more from artificial intelligence. Did we get to the cecum? Are we withdrawing in a good way? Are we sleeping and having blind spot? Are we monitoring the withdrawal time within the 6 to 10 minutes as explicitated by the performance measure of the quality committee of ESGE. This is, for instance, what is in EndoAngel that led to an increase of the adenoma detection rate, although the starting point was only 8% up to 16%. This is very nice courtesy by RAF, showing that we can measure the size of the polyp, and again from RAF the possibility to have an automatic report with the computer taking the information by the image in the field of localization, measurement, morphology, and resection, etc. So my take-home message is that detection remains the most easy to implement task of AI in clinical practice, and you will hear from Micheal. Characterization remain one of the main needs, but its clinical implementation will be much more complex also for medico-legal issues. That is the difference between CAD-X and CAD-E. Quality assurance, on the other hand, is something that, in my view, will come very soon on our AI portfolio, and we need additional study to estimate its effect. Thanks for your attention. We'll get back to your question, and I give now the talk to Micheal.
Well, thank you, Cesare. Thank you for your great overview about the exciting new technologies that's ahead of us. What I'd like to do now is to give you a little bit of an inside view behind the scenes, how the discovery system was developed. And like everybody else, I'd like to underline the importance of improve the quality of screening and colonoscopy. As we all know, we're dealing with voluntary, healthy individuals, not patients, and we're doing an invasive procedure. So we have to make sure that we get the highest quality possible in order to get the best results and to justify this invasive exam. And as we know, local cancer has a very high survival rate, but the more advanced the cancer is, the worse survival becomes. Fortunately for us endoscopists, there is a relatively slow progression from adenoma to invasive cancer, which justifies screening colonoscopy. So by identifying and resecting adenomas and benign polyps from the colon, we can avoid cancer and therefore avoid complications of cancer like chemotherapy, surgery, or death. And as you've heard from Raf and also from Cesare, this strategy unfortunately is far from perfect, mostly because of the human factor and therefore the existence of so-called interval cancers. As you've heard, the polyp miss rate can be considerable, and not only we just miss polyps, but we also miss advanced adenomas. And advanced adenomas are missed in roughly 5% or more than 5% of colonoscopies, and interval cancers account for up to 9% of colon cancer patients in total. So this is quite a big chunk of cancer patients who had a colonoscopy where a significant lesion was missed. And apart from artificial intelligence, we've been trying to improve our quality for quite a long time. We started with transparent caps. We started using add-on devices like endocuff or endorings, or by the development of smart endoscopes like the third eye retroscope or the GI endoscope, which has a balloon which stabilizes at my position, which flattens the fold and allows for more closer inspection of my mucosal surface. But as you've heard from Raf, we all get distracted, we all become tired at the end of a long day. So human factor is the most important variable, also because we know not everybody recognizes significant lesions like flat polyps in the colon. The development of the discovery system has actually very fast. And this is also probably because we as clinicians have been involved very early in the development of the system. And we have been involved in various ways. First, of course, we acquired the training data and the learning data sets for the deep convolutional network. we had the little tedious task of marking and characterizing lesions. We also resected all the polyps we found during the colonoscopies we performed, and then we had to correlate our findings with the histopathology of the resected specimens as the gold standard. But throughout the time of the development, we have been in close contact with the developers, and we gave them feedback regarding the results we had in the initial versions of the program and the usability of the system. And therefore, it only took us less than a year to fully develop Discovery and to get the system you can now buy and use in your own unit. So just to show you some very early prototype, this was the first material I got to see with the training data we started. You can see that the boxes look different from the final version, but already in the first data sets, we had very good and reliable recognition, also from several polyps. On the right-hand side, you have a more classic lesion. But what you can see that already in the distance, before you as an endoscopist spot the lesion, due to the fast reaction time of the system, we can spot the polyp and then get a closer look and find the polyp we might miss during a conventional colonoscopy. So this is a very early prototype. Not many people have seen this, and the final result was even better. So is the development of the Discover system over? Are we having a final product? No. So what we're still doing, we try to fine-tune the sensitivity and specificity of the neural network. We've seen especially good results in flat lesions, which are very difficult. So we put all our expertise into identifying correctly and finding sessile serrated adenomas. We also have been giving feedback regarding the usability. So the user interface is really intuitive, it's really simple. And we also formed a network of users all around the world to create scientific evidence, because we don't want to be lured by nice pictures and spectacular videos. We also want to create behind the evidence behind the technology. And as many of you know, we're starting a large multi-center trial in order to get the evidence we need to justify the acquiry of such a system. The development is quite satisfying for us as physicians. We've been involved from the beginning. So before we had an actual working prototype, we were invited to so-called black box innovation meetings at the development center. So we had direct interactions with the developers. They were not just a group of computer freaks and mathematicians sitting in their cubicles developing a system, but we discussed from the start what we'd like to have in the system, what we'd like to see, and therefore I think most of our expectations have been addressed and even exceeded. Cesare mentioned that we have still so many interesting fields to come for artificial intelligence in endoscopy, and I'm glad to tell Cesare and you that some of the things are already in the pipeline. So we started from day one with classification of polyps in mind. That's why we resected our lesions. That's why we classified the lesions, so we didn't only detect them. So classification is something you will see really soon. We also started to work on other organs. Cesare showed an example of Barrett's carcinoma. We're also working on other precancerous and early cancer lesions like gastric cancer, squamous cell cancer in the esophagus. So stay tuned to see more in the future. And of course, we're also working on automation of endoscopy reports and automatic recording of quality indicators like cecum intubation and withdrawal time. Here's just another video clip. What you can see here, that also multiple polyps are detected reliably by the system. What you can't see is that the reaction time is 0.1 second. So usually my discovery system spots the polyp before I do, because obviously it has much more computational power than I have. regardless of the day of time and the number of procedures are performed. And another advantage is that with EAI system, if a lesion is barely visible at the border of the screen, it immediately alerts us, so we can detect lesions which are visible just for a second. And this is also a very nice example. You have a bad bowel preparation, you have a sessile serrated polyp with a mucus cap, and the system doesn't get confused by the stool and still detects reliably those easy to miss and not always easy to recognize lesions in the colon. So coming to my conclusion, I think we'll see artificial intelligence systems like Discovery routinely used in the colonoscopy in the near future, and it will probably also become a prerequisite in order to offer good quality in our screening populations. The PENTAX Discovery system has been developed in close cooperation with us physicians, so it can be used under any circumstances. It can be used with eye scan, it can be used with white light. So we try to implement all these features, and in our initial experience, and most of us have been using this system for almost a year now, we've seen very reliable detection of also very difficult lesions like flat sessile serrated adenomas. What we've seen already in our first data is that we see a clear increase in polyp and also adenoma detection rate. The first abstracts have been submitted. The sensitivity for the detection is 90% with good specificity. And of course, the system is very easy to use. You don't have to be a computer wizard to use the Discovery system. You have an acoustic feedback and a visual feedback if a polyp is detected, and that makes use on a daily basis very easy and intuitive. And what we've also been doing, we've created a network of users to further study the technology, and we are in constant exchange with the developers and looking forward to introducing new features over time with the existing hardware, and try to improve and further expand the system's capabilities. And with that, I thank you for the attention. I'd like to hand over to the next presentation to Amyn.
Thank you very much, everybody, and welcome tonight's meeting. So my remit for the next 10 minutes is just to take you through, our aspect and our way of treating polyps that have been discovered. And you've heard two excellent speakers just before this. So the remit for the next 10 minutes is just to take you through the different options for endoscopic treatment. We know that you can do piecemeal EMR or indeed ESD, or do we make decisions regarding full thickness surgery or laparoscopic surgery? And one of the difficulties is that diagnosis is often very important, but decisions are often made on local expertise rather than actual diagnosis itself. And if there is early colorectal cancer that's suspected, we must have a discussion with patients regarding the risk of lymph node metastasis and identify those lesions that are technically resectable by ESD, in particular for risk of early submucosal invasion. So if we do suspect invasion, we must provide the pathologist with a single fragment, which includes all of the submucosa. So the overview for this talk is really to look at the endoscopic diagnosis, and what are the indications for treatment, and a few words on pathology at the end itself. So in our practice at King's, what we use is magnification endoscopy, and this is magnification endoscopy using either indigo carmine or crystal violet to look at the Kudo pit pattern to identify those lesions that are indeed higher risk, such as 5i pit or 5n pit, which are indicative of submucosal invasion. And also vascular pattern. There are many classifications, but here is one particular classification where we look at the network of vessels on spectral imaging, and there are many different classifications that are used around the world. This is a nice classification which subdivides into 3 types. In our practice, we would use JNET classification, which really looks at either being type 1, which are hyperplastic polyps or sessile serrated lesions, or type 2, which have either got regular vessel pattern or slightly irregular, which will be indicative either of low-grade intramucosal neoplasia or indeed high-grade dysplasia, and then very disrupted pattern, which would be indicative of deep submucosal invasion with type 3. And, with spectral imaging, we can use and detect those areas that are slightly irregular and therefore use dye spray with chromoendoscopy to evaluate those in much more detail. So here are just examples really of how we would assess, looking at different polyps using chromoendoscopy and spectral imaging, not only to look at the pit pattern, but also the spectral imaging for vascular pattern itself, and then make a decision regarding en-bloc treatment. So how do we do that? And I want to focus for the next 2 minutes or so just on these particular type of polyps, which are lateral spreading tumors, which is a bulk of lesions that we might find referred for endoscopic treatment. And these can be subdivided into granular type and non-granular type. And as we go from top left to bottom right of the screen, there is an increased risk of submucosal invasion, and there's an increased risk of more multifocal invasion as well. So let's take these into detail quickly. So LSTG homogeneous type, the risk of submucosal invasion in our practice is very low, less than 1%. When I was at Showa University with Professor Kudo, the risk of submucosal invasion, is still less than 1%, and therefore many of these lesions can be treated if there is a large lesion in the right colon by endoscopic resection, by piecemeal resection, because the risk of submucosal invasion is low. However, we need to consider the cost of recurrence. And if you look at the recurrence of patients that we have large lesions that have had piecemeal EMR, then the risk of recurrence is nearly 14%. And often these patients require more screening colonoscopies to achieve a completely clear colon, therefore increasing the cost of treatment and also potentially some patients requiring surgery. And one of the other issues is that this long surveillance often also leads to recurrence that's much later, that can potentially be up to 3 years after. What about patients with LSTG mixed nodular type? Well, these have a much higher risk of submucosal invasion, and 19% in the Showa University Professor Kudo's series, and therefore we would advocate en-bloc resection for these patients by ESD and then sent to the pathologist in one specimen. And looking at patients that are LST non-granular, LST-NG, the risk of submucosal invasion here is much higher. For LST-NG flat type, the risk is about 10% overall, but if it's pseudodepressed type, then the risk could be 40% and quite significant. And often these are multifocal with increasing fibrosis, so paramount importance to treat these by en-bloc resection and ESD. So just to summarize this, if we've got patients that are in our practice, what we do when we find these polyps, we would use magnification endoscopy, use spectral imaging, and then if it's 5-eye pit to LST-NG, they would have ESD en-bloc. And with the 5-eye pit, you can go into more detail, but a lot of endoscopists may not feel that they want to go down this route, but you can divide them into the 5-eye pit into much lower grade and high grade, and this may give you an indication of whether this is high-grade dysplasia or early submucosal invasion. And just to give you some images, this is something that's a low-grade 5-eye. This is some area which is slightly higher grade 5-eye, which is early submucosal invasion. And when it's non-structured itself, it's deep submucosal invasion. So putting the three together, you can see the difference really, that there is irregular, a little bit more irregular, and then completely unstructured, and going from high-grade dysplasia on the left to submucosal invasive cancer on the right. So in our practice, what we would do, because we're not as proficient with magnification endoscopy like our Japanese colleagues, we would, if the patients have 5-eye pit, we would make sure that it's favorable with high-frequency mini-probe ultrasound prior to resecting to ESD. And obviously, if it's 5N pit, then patients need to go on to have laparoscopic surgery, or indeed need to have transanal endoscopic microsurgery, or TEMS, followed by chemoradiation in the rectum, if they don't wish to go down the route of lymph node harvest with laparoscopic surgery itself. So here's an example, an interesting case, a patient in the distal sigmoid colon lesion, where there's an early cancer. You can see that the ultrasound itself shows a clear muscularis propria. Patient is not fit to have laparoscopic treatment and doesn't wish to have laparoscopic treatment. But because this is an early submucosal invasive cancer, on magnification and on ultrasound, and therefore you can actually advocate doing an ESD and doing an en-bloc resection. On the bottom left here, you can see a live video. You can see the muscle layer here, which is quite separate from the submucosal invasive cancer, which is just here. So very interesting to use these two modalities in order to guide treatment itself. An LSTG mixed nodular type, we've said that we would do en-bloc resection by ESD, and what we would always advocate is identifying where the cancer is and then identifying and marking that on the specimen so that the pathologist can actually have an idea. So very important, particularly in the rectum, for large lesions with nodular component to do an en-bloc resection itself. We would still do the same thing for scarred lesions because EMR is more difficult for these lesions, and we would advocate doing ESD. And if you've got patients like this post-chemoradiation who've developed a big LSTG homogeneous type, very difficult to resect by EMR, and therefore we would do by ESD. And we've already spoken about LSTG homogeneous type, and you can offer them EMR, but do consider the recurrence. Just a couple of slides really just to finish on pathology. You need good collaboration with your pathologists so that we can identify exactly the layers and the areas that we're interested in, and 2 millimeter slices to identify the area of cancer, so we can identify the exact area of submucosal invasion itself. Obviously, ESD requires training, and we have programs in place. And Micheal's has given an excellent lecture prior to this. He's along with myself. We have some of the mentors that are involved in the Forward program, which is provided by PENTAX. This is a 1-year program of training. We have 12 trainees from 6 different countries with experts from around the world doing both hands-on training and mentorship to support them during their ESD practice itself. And obviously the considerations are very similar to what the ESGE have advocated really, which is a combination of hands-on in the lab, as well as observation and then mentorship, and then having some ongoing dialogue with your mentor online and video cases that could be actually used with Japanese and European mentorships itself. And in terms of our actual dissection tools that we would use, there's a whole host of different knives and tools that we can use. One comment just to make about this is we've now recently moved in the last year or so to using more bipolar in the colon itself, and the hemostat with bipolar is extremely useful to reduce the risk of actually injury to the muscle layer when you're using hemostasis itself. And this in combination with a flushing splash M knife provides an excellent tool for doing ESD in our practice. So just really in summary, I think endoscopic diagnosis is really the key for appropriate decision making, and we've heard some excellent talks about the diagnosis side and artificial intelligence, but really making the appropriate decision between EMR and ESD. And I think ESD really is playing a very important role, certainly in Europe, for treatment of colorectal polyps. I hope many of you can visit King's at some stage. We'd welcome you to our endoscopy unit. Thank you very much.
Well, thank you very much for the 3 speakers. I think 3 excellent talks focusing on AI and the pros and cons, characterization, but not only characterization, also detection, which is the main aim at this time. I think it was nice to see how the discovery system was developed and is developed, and but we need more evidence to show its advantages. And I think also the nice final lecture about characterization, also treating these lesions in the colon is important. So fulfilling the whole spectrum of new developments in the field of colonoscopy. And I think this is something that we will see more and more in the next few years to come. There's time for some questions, and I would like to start off with my first question. I'd like to ask Cesare. You were discussing also the risk of false negatives. And I was wondering, and I'm always wondering, what is the consequence of having a false negative in terms of medical legal issues?
Yeah, this is a very important issue, Peter, and this also come about the transparency of the system we use. Of course, any AI system will experience a false negative. This is somewhat reasonable unless there is a major pitfall in the training system. For instance, imagine that an AI system has been trained without any deep cancer. The endoscopy is not aware of this. The machine misses a deep cancer because the system was not trained. Who is guilty? The endoscopist, the engineer, or the health system? I guess that the engineer has some responsibility because he needs to be transparent about what is used for training the machine, so that the endoscopist should be aware that this machine cannot help in that situation. Of course, also the endoscopist has its own responsibility, but I guess this is a different problem. So I guess that all the actors here should be ready to be responsible for a severe medical error.
Well, that's something that needs to be learned, of course, in the near future. But I think that's indeed very important. Micheal, you have told us very nicely the path of developing the discovery system, and of course, I think it will be of help to all of us. But is there a specific group of specialists that you think for whom it could be even more helpful?
Well, I think the main group is first, of course, trainees who unfortunately always have someone looking over their shoulders and detect maybe flat lesions for them. But I think at the end of the day, everybody who's doing screening colonoscopy, I mean, we all happen to be tired or get distracted. So I think if we offer screening colonoscopy in a couple of years or so, I think this will be a standard tool in our hands.
Very good. Ralph, you have another question.
Yes, I just wanted to come back to the development a little bit. So it's indeed a very important regulatory issue to see how the system was developed. And with that regard, I would like to ask Micheal, so you showed in your movie different imaging modes. You used iScan, iScan OE. So can you say that the system was trained with any of these techniques, with all techniques? And was there any technique that might perform better? Because we know that some of these imaging modalities that create a better contrast actually can perform better for the endoscopist, and maybe the same is true for the AI system.
Yeah, so all the polyps we found during the training phase were assessed with white light and all modes of iScan and iScan OE. So I think we can reliably detect, regardless of personal preference. You might want to do a colonoscopy with iScan 1, but you still get reliable detection with the discovery system. I think the enhancement in contrast is not as important as it is in humans because we have less computational power. So the computer has much more horsepower and much more brains to analyze a lesion and much faster than we do. But we haven't looked into any details if, let's say, iScan OE increases the detection rate of flat lesions. Because obviously the system has been trained by experts. So what we see with either method is recognized by the neural network.
I think the problem might be that we're only using 10% of our brain, and in fact, it's much bigger than a computer. So, I mean, coming back to the characterization, I was really impressed by your high-quality images of these lesions and the way you assess them and indicate to your pathologist where you think the worst part is. But it's a really tedious task to do, and we will talk later on in about 50 minutes about the curriculum of advanced imaging. How long is the learning curve to learn this for endoscopists? That's the first question. And the second is, do you think that AI has the potential to improve prediction of deep submucosal invasion?
Yeah, I think it's a very good point, really. I think one of the main issues is that it takes a long time to get an accurate image. And really, it involves a combination of having the basics right in terms of getting a clear image, in terms of bowel preparation and irrigation and mucus clearance, prior to actually using it, magnification endoscopy. And one of the difficulties, with using magnification, as you know, is that you do need to keep that focal length very short. So you need to have good tip control in order to get that perfect image. So I think, it's not unusual to take 10 to 15 minutes to assess a large polyp in detail to get the most accurate image. And it really goes on to the points about, using AI for the diagnosis. We need to present a good quality image to artificial intelligence systems in order to get an accurate diagnosis. So really one follows the other, and often many systems where endoscopists are frustrated about, poor AI reference to deep submucosal invasion is often we've not presented it with the actually appropriate image itself.
So that also means that a system that is detecting is much more or easier to develop than a system that is characterizing a lesion.
Yeah, I believe so. I believe so. I think, the detection obviously is a first-to-first angle, and across the world, obviously, the diminutive polyps are the major problem. But, once we do find this, getting the characterization right is more of a complex issue. And I think that's sort of the second wave of development that we'll see across the next 5 to 10 years. And many systems already in place in terms of characterization, but to get good, accurate diagnosis and percentage and increase the probability of submucosal invasion, we need to have good quality imaging to be presenting to the computer in the first place.
Yeah, I fully agree. Micheal, I have a question for you. What are the type of lesions for which the AI system really may have an advantage? Is that for smaller lesions, bigger lesions, sessile lesions, whatever? Can you a little bit explain this in more detail?
Yes, well, I think that the main advantage is in sessile flat lesions, in flat lesions regardless of size. I've shown you one example of a fairly large sessile serrated adenoma, and regardless of size, those lesions are unfortunately missed quite easily. So everybody can detect a sessile polyp, but flat lesions are the ones we're missing, the ones responsible for interval cancers. And we all remember the studies from the Japanese endoscopists 20 years ago when they came to Europe and found what was back then called flat adenomas, because we Europeans did miss them. And still, I think frequently sessile polyps are overlooked, and that's where I see the main use of AI.
I see. Cesare, there's I think a question that comes in from one of the people that are watching this symposium. And it says, my experience with AI is a false positive rate of 70% or more than 70%, and false negative about 10%. And this author actually suggests that we need randomized controlled trials. And you were actually saying that we don't need randomized controlled trials. So what is your opinion there?
I mean, as physician, we should know there's no test is perfect. If we had a test of sensitivity and specificity 100%, we would not need a physician to interpret this. Any test has its strength and its weakness. I guess that it is to us as endoscopists to maximize the possible benefit and to minimize the possible harm from AI. So I'm very happy that people in the community get aware that these machines are not perfect. But what should tend to perfection is the interaction between us and the machine.
I see. So, Rolf, I have an almost, I think, final question for you. What is the impact of these AI system on the training of young endoscopists?
Well, I think that's a very interesting thing because you said developing is easy for a CAD-E system, which I think in fact is, but the implementation is another thing. And there may be a danger that people depend too much on the system. That has never been assessed. So you can have de-skilling of experienced endoscopists, and maybe you can have actually insufficient training of trainees because they only depend on what this system shows. This is one of the key issues I think that has to be sorted out in the future. And that's why I think any implementation of these techniques need to go hand in hand with the quality assurance in terms of measuring cecal intubation rate, extraction time, and also which part of the bowel is visualized. I think that will be very crucial, and maybe more important to have such a training AI system for the trainee to give feedback than just the CAD-E in itself.
Well, I think that's a very nice final conclusion of this symposium. I'd like to thank the speakers, of course, for excellent lectures. I'd like to thank you as well, Rolf. I'd like to thank the audience for being part of this symposium, and I'd like to thank PENTAX for making this symposium able. Thank you very much.